Hello, thank you everyone for joining CareerCert and UT Southwestern today. I am Paula. I'm going to be your host for this webinar. I'll do a quick introduction for our panelists and then I'll be in the back end answering any questions and monitoring the chat. So today we have CareerCert and UT Southwestern EMS sharing a very interesting case of chest pain with an ECG, and we'll be using ECG and EKG throughout. So this case is packed with many lessons, including a STEMI pattern. Our great panelists today will dissect the case information, the presentation, the ECG, and the surprising decisions that help the patient survive. But who are they, right? Who are presenting today? So we have three presenters. We have Dr. Salazar, we have Dr. Paladugu, and Rocket. So William Rocket. So Dr. Salazar is an associate professor of emergency medicine at UT Southwestern. He serves as a medical director of EMS education and oversees both initial and continuing education of area EMS professionals. He also practices clinically at Parkland Hospital Emergency Department and is dually board certified in emergency medicine and EMS and serves as core faculty for the emergency medicine residency and the EMS fellowship programs of UT Southwestern Medical Center. His main goal is to improve the quality of education in the management of natural and human-made disasters. Also joining us today, as I mentioned, we have Dr. Sravana Paladugu. She is a third-year emergency medicine resident at UT Southwestern. And while in college at University of Miami, she obtained her EMT certification. Then she completed her medical school training in Vermont, and after residency, she plans to stay in Texas to practice emergency medicine at a local community hospital. Last but not least, we have William Brockett, who is nationally registered EMT paramedic and full-time faculty of the EMS education program at Dallas College. He attended the EMT paramedic certification course at El Centro College in 2016 and has since worked in the field as a paramedic in both 911 emergency and interfacility transport capacities. He has completed various other EMS and teaching certifications and is currently enrolled in courses as part of additional degree plans. Our presenters today will be taking questions throughout, so be sure to share those in the chat. If you want to just ask a question live, if you dare to do that, we can go ahead and unmute your mic. Just let us know your question that you want that to be a live question, so I can do that. Then also, if you want to download the presentation from today, you can do that. There is a PDF that you can just click on download. If for some reason you can't do it, just also put it in the chat and I'll be able to send it to you separately. With all that, team, the floor is yours.
Well, good afternoon, everybody, and good morning to some of you, and happy lunch to many of you having a bite to eat while we learn some fun and exciting material related to EMS today. So very grateful to CareerCert for the opportunity to host us today, as they do pretty much every month, and it's been a very nice relationship going forward. And we thank you so much for all the feedback and for asking to have us back. It's really a pleasure being here today. My sincere thanks to my co-panelist today, Dr. Paladugu, who's been a phenomenal resident physician. She's been an amazing colleague, a great teammate, definitely as she looks to finish her career with us at UT Southwestern. I'm relieved that she's not going to be going far from home, and it's been an absolute pleasure teaching you, and thanks for joining us today. And you're welcome. And Will Rocket, also a phenomenal colleague. I've had the chance to teach Will in paramedic school, where he distinguished himself as an intuitive, highly inquisitive, and intelligent, very conscientious EMS professional, and so good that he now forms part of a generation of great educators. So very talented, Will. It's an absolute pleasure getting to work with you.
It's a pleasure for me. Thank you, sir.
You're very welcome. Today's case is going to be very interesting. One of the things that I've really enjoyed the last few months is walking you through a very EMS heavy case with some very heavy hospital kind of operational nuances to it. And the reason I like to do that is because I really firmly believe that patient follow-up following an EMS transport in the care of the injured patient in the field, I believe that feedback and that follow-up is very important for the practice of EMS. There's a lot of lessons to learn it's not just about transporting the patient, make sure that they're doing okay. It's really what can we learn from that call? What happened at the hospital level that our EMS professionals out there can learn from? So I'm going to take you through the case today, and hopefully you learn something. Please, I ask you if you have a question, put it in the chat. Paula will be looking out after that. And at the end, we'd like to open it up for live questions. So if there's a live question you want to ask, please take advantage of it. Our case today involves a 53-year-old Latino male. The paramedic crew was made up of 2 paramedics, 1 EMT who was looking to get hired with that agency, and was a third rider in the back of the box on that day. This Latino male presented to the place where he works. He works in the trucking business and had just completed a pretty large across the country trip. Once he got back to home base in that area, he began to let coworkers know that he had been having some chest pain located on the right side, approximately 3 hours prior to the him telling somebody about the issue. The pain, as the medics documented, did not radiate anywhere, so it looks like a pretty good OPQ-RST based on the run sheet. They documented a 6 out of 10 and mostly described as a pressure. It's pretty amazing to me that this documentation by the medics is so phenomenal. Really glad to see it. Really adds to the differential diagnosis. The past medical history for the patient is diabetes. The patient is compliant with his oral metformin. He does report a family history of heart disease, and that was reported later on at the hospital. His surgical history included a cholecystectomy, it's a removal of the gallbladder. And one of the reasons I put that in there is we always want to make sure we include gastrointestinal complaints in our differential for chest pain as radiating pain, gastrointestinal pain, just like my father with his myocardial infarction, he had GI related pain. He does smoke cigarettes, 4 packs per day. To me, that's one of the biggest drivers of heart disease. And so it's pretty amazing to me that the medics did such a phenomenal job. Very proud of them in their documentation. As part of the care that the patient received on that day, the medics provided a perform a 12 lead ECG, which Dr. Paula Dugo is going to share with us.
Okay, so next slide. Perfect. So here we have our first EKG. So we can run through this in kind of a systematic way. So we do it the same way every time, starting with the rate. It looks like his rate is about 100 here, so a little bit fast. Looking at the rhythm, it looks very regular. So we can call this normal sinus rhythm. There's a P wave before every QRS complex, and the beats are very regular. Interestingly, we see some ST elevations right away, especially V2. That's kind of where it's the most obvious, but if you look at V1, it's a little bit elevated in that lead as well. We have some minor ST elevations, maybe in leads 2, 3, not really AVF, and then some T-wave inversions in lead 1 and AVL. So overall, with this patient's story and his symptoms, and this initial EKG, definitely very concerning for ST elevation.
Thank you, Dr. Paladugu. And as part of the care given to the patient by EMS and given such a concerning EKG, I really, the pattern looks a little bit weird to me right here. So I would like to see what our audience members today think, how they would proceed. So Paula, let's go ahead and launch the first poll, and let's see if we're able to see what our audience members think today. So I'm going to go ahead and pause. Paula, do I need to pause the presentation to launch the poll?
No, I don't think you're seeing it. It's been happening on the last ones, but actually I launched the poll. So we have about 39% of our attendees voting. We still have them going on. So we'll give him another 30 seconds to 1 minute to keep answering.
Perfect. That sounds good. So since I'm the presenter, that's probably why I can't see it. So Will, what would you do with this very interesting patient with definitely concerning signs, definitely concerning symptoms, and now this EKG, and then I'll be really curious to see what the rest of the audience says.
Now, for me personally, as you have both noted, there are some very concerning things that we've seen here, both with their presentation, with their signs and symptoms, and what we've noted on the EKG itself. I would be very tempted to go ahead and activate code STEMI with this patient, but I would probably also pass on to medical control, get some additional eyes on it, because as was noted, it does look kind of strange. There's some funky stuff going on here. But if I did decide to activate code STEMI, I would be very deliberate in explaining the case to the receiving facility, letting them know of this somewhat abnormal presentation I'm seeing here with this right side of unilateral pain, with it non-radiating, all these other findings I've discovered. I'd be very deliberate in communicating that to them.
Yeah, well, I fully agree with you. At the end of the day, you do have a gentleman with all the risk factors in the world for acute ischemic disease. You have the right symptoms, you have the right signs in there, and definitely with this EKG, particularly in those anterior leads, I fully agree with you. I would activate a STEMI. Dr. Paladugu, you can probably see the results of the poll. Are you able
Yeah.
to share them with us? What does our audience think?
Yeah, actually, I love the answers because they're so evenly spread across the board. So about 30% would repeat the EKG, another 30% would activate a STEMI, another 30% would call medical control with the EKG findings. So
That's pretty interesting. That's right around where I thought it would be. And I
yeah.
think one of the big reasons is as much as we talked about STEMIs, this EKG is, for lack of a better word, a little bit funky. But don't get freaked out. We're going to discuss everything there is to know about this EKG. So let's go on to, as I really like to do, the let's see what we got here. Let's go ahead and talk about the differential diagnosis for this patient. And so that's going to be Dr. Paladugu.
Okay, so we have an elderly Hispanic male complaining of chest pain. He has a lot of risk factors like we talked about, and we saw his first EKG. So we're definitely concerned, like we talked about with MI. That's definitely a possibility, and that's a diagnosis that we can't miss in the emergency setting. Some other things that present with chest pain can be an aortic dissection. That can be a little bit more of like a tearing, severe 10 out of 10 chest pain typically. We always think of a PE, so a pulmonary embolism, which is a blood clot that has traveled into the lungs, can also present with chest pain, either side, any type of quality of pain as well. We always want to rule out pneumothorax, so lung sounds are very important. Pneumonias can sometimes be painful and cause vague chest pain type symptoms, so listening to the lungs is very important. And then a heart failure exacerbation. So if this man has an unknown history of heart failure, maybe not on the right medications, he can be having a buildup of fluid in his lungs and presents with heart failure exacerbation. You always want to think about that as well.
And also, in any instance of pain, previous trauma is listed within our differential diagnoses. And that can range from trauma that occurred really recently to trauma that occurred even hours or days ago. It is now resulting in additional inflammation and discomfort. Another possibility here is it could be associated with some form of rash. It could be caused by an irritant exposure, or even sometimes a shingles flare-up with the herpes zoster virus as well. Costochondritis is the inflammation of the cartilage that connects the ribs to the sternum. Could be a cause here. We see that a lot with unilateral chest pain, and it can sometimes mimic angina with additional symptoms. It can even radiate into the shoulder and the scapular region as well. Pericarditis is it's the inflammation of the pericardium and the pericardial sac. Is yet another possibility here, and we know that it has the potential to introduce some EKG changes. Similarly, myocarditis can do that as well. Those can be paired with each other frequently, and it is the inflammation of the myocardium, or the heart muscle itself. It presents with a lot of the same signs as ACS. It can produce ST segment changes. Frequently, it's caused by some form of infection, maybe a medication reaction, but it can be caused by other inflammatory conditions as well. Maybe lupus or radiation therapy, or even rheumatoid arthritis sometimes can be paired with it. So we know it's been discussed quite a bit recently with the increase of cases and its suspected relation to COVID-19 as well.
Well, that's a phenomenal point. And, one of the big reasons we always keep a wide differential diagnosis in chest pain is because there's so much other life-threatening pathology that can cause chest pain. So I urge our EMS professionals, those attending to you today, when it comes to chest pain doesn't equal one thing. It cannot be a linear approach to things. I'd like to show you very quickly kind of what the initial kind of documentation is once the patient is arriving to our emergency department. And here is just a snapshot exactly of once code STEMI is activated. The patient is kind of quickly gone to the cath lab, and this is the initial documentation by the care team. You notice there that there is a really low level tachycardia there. You notice a slight increase in the patient's temperature, normal respirations, and a normal SpO2 on room air. So no matter what's happening, the patient is ventilating, oxygenating, and perfusing very well at this point. This is verbatim snapshot of what was documented, that the patient is really well appearing overall. They do document the tachycardia. They did their due diligence in doing a quick exam, normal chest rise and fall, no edema noted. The patient was not diaphoretic, and the patient really was neurologically intact. So let's talk about what happened next. Things are flowing pretty nicely. So Dr. Paladugu, what happens once the patient gets up there?
So he goes to the cath lab as planned, but it looks like cardiology turns him away. They deactivate the cath lab based on his EKG initially, which we were very concerned about. But looking at the repeat, we get even a little bit more concerned. The ST elevations we talked about originally look like they're progressing and evolving and potentially a little bit worse. The second EKG is in the bottom right corner. And if you compare that to the other one prior, you can see V1, V2, V3 are all a little bit worse in terms of the ST elevations, maybe even lead 2. So patient still asymptomatic, still having chest pain, right story, concerning EKG. But we have him back in the ER now. He's back in our ED bed, back in our care.
This doesn't happen very often. I have consulted cardiology many times throughout the course of my career, and sometimes I need them, sometimes they don't, sometimes they really need to see the patient, sometimes they disagree with my evaluation. What I've never seen before is kind of an established hospital process in which the patient goes up and then the patient is kind of quickly turned away. Literally, the patient is on the cot, and really with no other choices. I'm going to address something in the chat right now. Somebody noticed that the rate on the EKG is approximately 60 to 70. And the documented rate at the time of the patient arrival to the cath lab is 100. Yeah, just to let you know, the EKGs, that was the documentation in the cath lab. So at that point, maybe the patient had a little more tachycardia on the monitor, but not reflected on the EKG. So good observation on y'all's part. So Will, we're about to launch the poll because I'm really curious to see what our audience would do today, and I want to see. I don't know if you've run into this. Probably not. So tell me a little bit about kind of how you proceed from here. You're up there with the patient. You got a line established. You got a 12-lead ECG, very concerning for a STEMI, and you follow a due process for that organization. And the patient, as soon as they're kind of arriving at those doors, that team tells you, no, actually, no, that doesn't work out very well. Like, how would you proceed, and how would an audience proceed? I'm going to launch a poll. What do you think, Will?
Yep.
So for me, I actually have had this happen twice. Only one of them was I still very involved with the patient care. They were still in my cot as we were walking in. The other time, I was just at the facility still kind of finishing things up. Both chances, I had the opportunity to speak with some of the providers, and I just did my best to clearly, and here's the key here, respectfully discuss my suspicion of cardiac involvement, kind of some of the signs and symptoms, the presentation of the patient. But when I said the big thing here is respectfully, that is so key because we recognize that in the medical field, there are a lot of type A personalities, or at least in my experience there is, and that creates the potential for maybe some conflict or strife when opinions don't align. And it's really easy for us to kind of flare up, especially if we're working towards that ideal best case patient care, which hopefully we're all caring about.
I love something that you said, Will, related to the word respectfully, and I think that needs to be highlighted. We are going to often have disagreements amongst members of the health team across various disciplines. I mentioned sometimes the cardiology service disagrees with me, or they may disagree with Dr. Paladugu. We don't always see eye to eye on things. And I think one of the most important aspects of EMS, kind of as it pertains to this case, and as it pertains to life overall, and dealing with members of other parts of the care team, is going to be kind of conflict resolution. That's not something that is innate to us. It's not something that they teach us in EMT or paramedic school. And it's really only highlighted unless you go to kind of high level courses. So I really urge all of you, especially those who are leaders here and those with leadership aspirations, that conflict resolution needs to be an integral part of what we do. Dr. Paladugu, share with us the results of the poll. What's our audience looking at?
Okay, so about 60% of people will repeat the EKG again. Another 30% will call medical control, and about 10% will just turn around, go back to the ER.
I gotcha. Yeah, absolutely. I think all of those options are going to be pretty reasonable. Not an easy way to go, and this happened in the middle of the day, but it could have happened at 3 o'clock in the morning, and decision making can be really tough. So as we move on to the next slide, I want to kind of start highlighting what happens next. The patient gets taken back downstairs to the emergency department, and all of a sudden a patient that nobody knows anything about, including the care team, all of a sudden absorbs the care of this patient. So Dr. Paladugu, talk to us a little bit about what starts happening at that point.
So now we have this patient having chest pain and evolving EKG. So like we do, we'll get an IV, we'll send off some labs, hook him up to all the monitors, make sure he's stable. But one more thing that we can do in the ER that's very useful is a bedside echo. So we have these portable ultrasound machines that are readily available. No radiation, it's right there next to the bedside. So we don't have to send the patient off to a CT scanner, but within seconds, we can see the heart, see the lungs, and learn a lot of very important things. So the big things we look for on a bedside echo in the ER in a patient like this is how his heart is beating, and if the wall of the heart or the muscle of the heart is beating symmetrically. So if there's one little part of the muscle that's not beating as strong as the rest, that tells us that area of the heart isn't getting enough blood supply. So that would support a diagnosis like an MI, which we are already very concerned about. We talked about the differential diagnosis, including a pulmonary embolism that can cause the right side of the heart to be very abnormally enlarged. That we can also see with the ultrasound machine. We can look at the lungs and make sure there's not a lot of fluid backed up into the lungs, see that the heart's beating strong enough to kind of rule out a heart failure exacerbation. So looking at this echo report, we can kind of tell it was really difficult for the providers to get a good view, which is common depending on the size of the patient, if you can get in between their rib spaces or not. But it looks like they were able to see a thrombus within the heart itself, which is a blood clot in the heart, which is very concerning, as well as some regional wall motion abnormalities that we talked about earlier in the septum, the anteroseptal wall, and the inferior septal wall of the heart is kind of not beating as strong as the rest of the heart, telling us it's not getting as much blood flow as it needs and supporting diagnosis of MI.
So one of the big reasons to show you some of these results is really a threefold kind of matter for me. Number one, you should remember that the reason we're showing you these things and the reason we're showing you these very abnormal results is because this patient was remarkably sick. And notice a little something that we noted earlier. He was documented as being well appearing, talking to you, really with very low level tachycardia. So this is a well appearing patient, walk around with some really serious pathology. And I teach this to my paramedic school students going back to even before Will's class, that well appearing patients can walk around with some really, really bad pathology. And kind of the concept of just looking at patients and saying sick or not sick based on appearance, that can be full of fallacy right there. Number two, I want to highlight how sick the patient really was here. Dr. Paladugu alluded to the fact the patient's got a thrombus in there, a clot really within the heart itself. Clots, they're not normal really anywhere, but when it comes to clots within the heart themselves, that's some serious pathology. So more than likely there is some type of injury, inflammatory process, sometimes infection, etc., that can lead to these collections of blood and material within the heart. And as all of you know, sooner or later, these things can travel to places where you don't want them to. So that's the second reason why I wanted to show you this result. And last but not least, I wanted to wet your whistle a little bit and kind of do a little foreshadowing. I foresee the days where we're going to start using this technology a lot more in EMS. So I just wanted to wet your whistle a little bit, kind of pique your appetite, a little appetizer. We're going to discuss ultrasound here shortly. So, all right. Well, one of the big things for us in EMS, I am a big proponent of once you have a patient in front of you, no matter what happens, no matter where they came from, no matter who called, we owe it to the patient, we owe it to our communities to have ownership and accountability for the patient. And I don't agree with the decision to turn away an EMS crew. I am very happy to see that the care provided to the patient once he came to the emergency department was we jumped on that patient. So, Will, what pearls of wisdom can you share with us in terms of accountability and ownership? What is your personal philosophy?
Well, you know, one of the common themes across the medical profession is, or at least should be, our patient advocacy. We hear that all the time, and with good reason. And part of that is recognizing that any time spent in which the patient does not have someone willingly responsible for their care, which can easily happen in the instance that you mentioned of someone who is presenting very well, even though there's the potential for some serious pathology, that any time spent without care creates the potential for lack of an adequate response. And that doesn't go away when a less than ideal response has already happened. So accountability can rapidly get complicated when there are so many providers involved. You know, we as medical professionals have a responsibility to hold the well-being of our patient as a priority. And I'll be the first to admit that I'm not always perfect at that and don't expect to ever be perfect, but I do aim to consistently get better about that and to strive to bettering that end. One of the big bad words we hear pre-hospital, you know, is abandonment, with good reason again. We know that we can't cease patient care until a specific set of events have occurred. You know, whether it be competent patient has refused care or care has been transferred to an equal or higher level of medical provision. And the possibility of abandonment doesn't stop at the pre-hospital level. This is a continuing thing. And across the board, we still have that responsibility towards aiming towards the best care for our patients that they can receive.
Thank you, Will. No question. We're going to run into situations many times in which we feel like patients are quote unquote dumped on us. And no matter what happens, it is somebody's father, somebody's mother, somebody's sister, somebody's wife. And we owe it to that patient and our communities to have full ownership, take full ownership of that patient and their care. So you may be wondering now, all right, so was it that clear cut? Why did the cath lab start? Why did the cath lab turn EMS away? Now this is where it gets a little bit interesting there, guys. So this is going back now to the care of the patient in the emergency department. Notice that really everything happens so fast that the first documented set of vital signs when the patient is downstairs with us is the same one as when the patient was upstairs a few minutes prior. That's how quick we jumped on this patient as a care team. So what is happening to this patient? Let's discuss this. Dr. Paladugo, go ahead and tell us a little bit about what's happening, what these tests mean, what are we doing to try to figure out what the patient, because it's not so clear cut, not a clear cut STEMI.
Yeah, so it looks like we're finally getting some of those labs back that we had already sent off, and they're really concerning. Looking at the troponin, it's over 3,000, which normal for us at UT Southwestern Parkland is less than 6. So 3,000 is a huge number. Definitely tells us his heart has definitely been damaged very recently. And then the next lab value is the N-terminal BNP. So that's about 2,000, which is also very high. That typically gets elevated when the heart muscle is either being stretched out or irritated or inflamed in any way. And then looks like his white blood cell count is a little bit elevated, so some inflammation going on. The A1C is super high, so kind of shows us his diabetes has not been well controlled. Normal A1C is around 6, his is 12. And again, we have a read of that second EKG saying, yes, definitely concerning for ST elevation.
Looks like Dr. Paladugo is cutting out a little bit. So just to interpret that for you, looks like the patient is receiving the aspirin, the morphine right here, and the care of the patient is being transitioned over to the cardiology team at that point. Oh, apologies. I think we got a little bit of a lag right there. So now that the patient is being now transitioned over to the next stage in their care. We know that there is an inflammatory process going that's affecting the myocardium. We know that the EKG is giving us also electrical signals suspicious for ongoing injury. And we know that the emergency department team is treating the patient exactly as if they're having a myocardial infarction. So the next step for the patient, in order for us to try to figure out what's going on, is to take the patient back to the cath lab, this time around for what we call a left heart catheterization. And that is a part of percutaneous coronary intervention in which we insert a needle on the patient's one of their vessels, either in their groin or in their arm, and kind of pass a guide wire all the way to the heart and try to figure out what's going on. Let's take a look at just what the left heart cath shows, just to show you kind of what's happening here. We know that the reason we're sending the patient to the cath lab here is because we're concerned about not just the myocardial ischemia, but now we're also very concerned that the patient has pericarditis. Okay, now notice right here that in the post-procedure diagnosis, once we've taken a look at what's happening in the patient's heart, we have some elevated left heart pressures, which can happen in these situations. But most importantly is that the patient has 3-vessel coronary disease with a rupture in the proximal LAD. Now, what this tells you is that this patient has been walking around with some pretty significant um, coronary disease for a while, and it became so critical now that he is becoming ischemic. Okay. Now, one of the things that we were able to see as part of this workup in this echocardiogram is that the patient has pericarditis. There is some inflammation noted of the heart muscle. And the amount of disease is so significant in this gentleman, in this patient, that the recommendation is to go ahead and do a cardiac bypass on the patient. Paula, would it be possible to mute Dr. Paladugo, and I'll text her and just let her know
Yeah,
what's going on?
I'm actually trying to do
Oh,
that.
no problem. No problem. And so the treatment for this patient is going to be to provide him with the aspirin, just like we do in EMS, give him some analgesics, but also the treatment is going to revolve around a go ahead and doing a bypass for the patient. So that tells you that the patient was remarkably sick. So in summary, what we have now is a gentleman who is 53 with the risk factors necessary for you to say that he does have ongoing coronary disease. And we know, based on the history now, based on the EKG, and based on his left heart cath, and all the studies that we did, that the patient actually probably had an ST segment elevation myocardial infarction several days prior. And what you're seeing then is that the patient now has the sequelae, the consequences of this myocardial infarction presenting. Isn't it amazing that the patient really started having symptoms only 3 days ago? So the term silent MI, which I hear a lot, maybe perhaps it is the real deal in a lot of patients. Maybe because of his diabetes, he wasn't having any symptoms. One of the biggest problems, to show you how sick this patient was despite being really well appearing, was that this thrombus, this clot within his left ventricle, made him a very poor candidate for immediate bypass surgery. And the reason for that, not to kind of belabor too much on the details, was that that thrombus can travel somewhere, can create a stroke. One of the treatments for this thrombus is going to be to thin out the blood, use anticoagulation. And if you try to perform a bypass surgery at that point in time, you're gonna run into quite a bit of trouble. So what we decided to do for this patient is to go ahead and treat him medically. We did start the anticoagulants for the patient, and we went ahead and put the patient in the cardiac care unit, where he really remained chest pain free, underwent additional studies, and once he was his blood was kind of thin enough in a safe level for him to go through a bypass surgery, they did go ahead and put 2 stents in his left anterior descending artery and his left circumflex. So that buys the patient a little more time in terms of opening up those coronaries until a later point, maybe in life, he will need a bypass surgery. In order to treat the patient, we did a triple therapy for this patient. And just to show you this, some of these patients do wind up needing high-level anticoagulation for a while. So we use the aspirin, the clopidogrel, which is Plavix is the trade name. It's just a different mode of anticoagulation, and a third medication called apixaban, which is a factor 10A inhibitor. So let's go ahead and talk a little bit about STEMI.
Sure thing. So classically, we use 2 specific criteria when we are making the decision whether or not to activate the cath lab based on our EKG, with some extra details sprinkled in here and there. So these criteria are new ST elevation in 2 contiguous leads. That means elevation noted in 2 or more leads that are roughly speaking, looking at the same area of the heart, or the noted presence of a new left bundle branch block. Now, it may seem strange to see something as specific as a new left bundle branch block as one of our criteria, but we find that while left bundle branch block can be one of our ACS mimics, at least on an EKG, it also has a high frequency of occurring along with or as a result of ACS. Both of these criteria are significant electrical signs of ongoing cardiac ischemia, hopefully leading us to the conclusion that the patient is in need of a rapid PCI, a percutaneous coronary intervention. But if PCI is so beneficial to patients with possible cardiac ischemia, why don't we activate the cath lab as soon as we note just any kind of ST segment elevation on an EKG? Dr. Salazar, did you want to expand on that any?
Yeah, absolutely. We'll mention that these electrical changes that you note on the EKG, they're diagnostic of ischemia. This is electricity's way of telling you the signals across the myocardium are very abnormal. One of the things that can throw people for a loop when it comes to EKGs, particularly in patients with signs, symptoms of myocardial infarction, is a left bundle branch block. And I wanted to go through these Garbosa criteria very quickly. Now, there are some revised Garbosa criteria. This is not going to be the main focus of this, but I just wanted to remind you that in order for you to say there's a left bundle branch block, but there's still the concern for an ongoing myocardial ischemia, you need to kind of go through these criteria. So let's go through them very quickly. One of them, ST elevation of greater than 1 millimeter concordant with the QRS. All right, you see that right there at the top, a normal left bundle branch block versus that ischemic type of pattern where you see that ST segment elevation greater than 1 millimeter. The second one is a 1 millimeter ST segment depression concordant with the QRS. You see normal there on the left, and then you see that ST segment depression concordant with the QRS on the right. That is diagnostic for ischemia in a left bundle branch block. And then the last one that is pretty easy actually for me is whenever you have that tombstoning that's greater than 5 millimeters in those leads, particularly in the anterior leads, that is, no matter what happens, that is going to be an ischemic pattern regardless. So just think about what a normal looks like, what the ST segment should look like, what in terms of elevation, in terms of depression, and really if you see tombstoning, especially if it's 5 millimeters or more in a patient with a left bundle branch block, you can go ahead and safely say this meets STEMI criteria. Now, what caused this inflammation that the patient has? So remember that the patient started having symptoms really 3 hours prior to arrival, but he probably started having ischemic type of changes in his myocardium really probably a few days before, maybe a day or two. And when we saw the echocardiogram, when we saw those changes, we saw these findings consistent with pericarditis, inflammation of the pericardium. So what happens in this patient? What are the common causes? Well, we see this from time to time in patients with viruses, kind of some of the kind of higher level types of colds, including influenza. We see this in patients with inflammatory processes such as lupus, rheumatoid arthritis. We see this in patients with cancer. Sometimes it's a result of the medications that they take. We see this in patients with certain infections such as tuberculosis. We see this in patients with kidney disorders in which their urea levels go up. That can also inflame the pericardium. And then one of the most concerning ones is this concept of a post-myocardial infarction pericarditis. And there's really two flavors to it. All you need to remember is something called Dressler syndrome, which is massive inflammation of the pericardium associated with some valve abnormalities as well. And it can also occur very early on in the process after an infarct, which is probably maybe what happened to this patient. This was a very rapid type of presentation. Some of you may remember from EMT or paramedic school that the classic type of pain pattern is that it's pleuritic. It's inspiratory in nature. It can be very sharp. Sometimes it's positional, kind of better when the patient is sitting up, kind of worse when they're laying back. You might remember some exam findings such as this friction rub. This is very harsh, kind of like a motor type of sound, and sometimes it's accompanied also by a pleural effusion fluid within the pericardium that's noted on exam as muffled heart sound, so low voltage on your EKG. Now we're going to talk about the EKG changes here. So let's go ahead and talk about the EKG changes so that I don't dive into ST segment elevations and PR depressions.
Sure thing. So now that we've noted many of those specific changes that we can see on an EKG as a result of pericarditis through the last few slides, we can also note that it tends to progress generally through 4 stages of EKG changes over time. Now, stage 1 is when we would expect to see this widespread diffuse ST segment elevation on our EKG, usually across the majority of our limb leads and the majority of our pericardial leads as well. Usually this is the one that gets us pre-hospital most into that STEMI mode of thinking. We see this ST elevation across the board and we're like, oh my goodness, what am I looking at here? This is a big deal. Now, it notes on here, we see PR depressions. That is less common, a little bit less specific, and it's not always used as a diagnostic tool since it's not as frequent. And it is an interesting thing to note if it is present. Something that really stood out to me was interesting here, though, is that we see the possible presence of reciprocal changes in AVR. Now, I don't know about y'all, but in my experience, a majority of pre-hospital ALS providers, we get into this mode of almost being completely blind to even the existence of AVR in our 12 leads anymore. We just kind of write it off eventually. But as you find, and we're seeing an example here, there are some really interesting things that we can find. This is a great example of one of them. Now, as time goes on, as we move into 1 to 3 weeks or so, we see this regression of the ST changes. They'll kind of normalize a little bit, but we can start to see this flattening of the T waves. We start to see abnormalities in that ventricular repolarization. As it gets into stage 3, those T waves can even become inverted as the weeks go on. And hopefully, eventually, in stage 4, we'll see this normalization of those ECG changes, and they'll kind of balance out in a return of relative normal for the patients.
We got Dr. Paladugu back, so just in time. We got through the EKG stages. Dr. Paladugu, Will, one of the things to note, you mentioned AVR, and AVR in and of itself, sometimes you can notice elevation in AVR. In and of itself, there are some camps that kind of stick to this AVR elevation as a STEMI criteria. Yours truly believes in ST segment elevation abnormalities in AVR more as an ongoing sign of ischemia, much more than a STEMI criteria in it and of itself. So the way I look at it is I'm looking at an EKG, and if I see ST segment elevations in AVR, I know that there is probably ischemia somewhere within the myocardium, but the AVR lead in and of itself doesn't tell me where. When I see it, I think about, let me look in other leads and think about where else I could look. Dr. Paladugu, do you have any thoughts? Where do you sit on the camp of AVR elevation? Oh, nope, I don't think we have Dr. Paladugu on this one. All right. Sorry, Sravana. Let's go ahead and move to the future of ultrasound here. I am a firm believer in remaining innovative, never becoming satisfied with how we use technology, how we leverage new technologies for the better care of the patients. And I'm a firm believer in putting these tools in the hands of the people in front of the patient. especially when it's very early in the patient's treatment, as we do in EMS. I think that if we become complacent in how we utilize these technologies, if we reserve them strictly for the hospital, I think that we can do patients a disservice. So I wanted to kind of bring this to your attention, just in the spirit of pushing forward. And I'm gonna while we're talking about this, I'd like to see if Paula can launch the last poll here. Is how are your agencies using ultrasound? And I'm gonna, as we talk about and looking for the results, and Will, please help me out with the results once they start popping up. I think there's some items in point of care ultrasound, especially for this type of pathology, myocardial and pulmonary pathology. I bring your attention to three things. Number one, I think it can be a phenomenal use in termination of resuscitation decision making, so that many agencies have to call medical control. They need to have a systole or PA documented in the EPCR on the monitor, and they're required to call medical control. Well, how awesome would it be if we're able to, in real time, have a monitor going that says, looks like a systole, looks like PA, the patient is unresponsive, there are no signs of life, and we're able to put an ultrasound probe on the patient's chest and see that wall motion is zero or very negligible. And you don't have to call medical control. This is the wave of the future. Two, lung exams. When it comes to patients who are volume overloaded, there is something called B lines. These are very pathognomonic. They're very specific for fluid in and around the thorax, especially in patients with pleural effusions, like in congestive heart failure, for example. These B lines, which we can see on ultrasound, give us a really good idea about the presence of fluid within the thorax, and allows us to tailor our therapy a lot faster. Remember that not every patient that you're going to see who's volume overloaded has crackles on exam, for example. So how amazing would it be to literally put a probe on the patient's chest, see B lines, and begin your nitroglycerin, begin your diuretics if you carry any, or your positive pressure ventilation on a patient. And last but not least, the one I'm the most excited about is using your point of care ultrasound in the inferior vena cava. That is also a very easy exam. It can give us a really good idea about the patient's volume status, especially in patients with suspected shock. It could be hypovolemic shock. It could be cardiogenic shock. And the quality of that inferior vena cava by ultrasound can give us a really good idea about what the patient is doing fluid status wise. So if the patient has a very kind of flat, collapsible inferior vena cava on Sono, is one view, and one view only, we can say definitively the patient has low volume status. Sometimes the IVC looks very full, not very compressible. It looks humongous. I can say with a really good degree of certainty the patient has good volume going, or they're volume overloaded. So these are exciting ways of using Sono. Let's see, Will, what does our audience think about the use of Sono? What are they using it for?
So our number one answer for this was actually for echocardiogram, which was closely followed, or somewhat closely, by CPR efforts, right around 25%, then followed by internal hemorrhage at 18, IV access at 11, and obstetrics at 7%. That echocardiogram was all the way up at 39% of the responses.
That's fascinating. Will, where do you sit in this and in this ultrasound conversation? Where do you see what would excite you the most?
I think the top two answers are kind of where I was sitting as well, kind of echocardiogram and with CPR use, just like you talked about with determination of resuscitation efforts. Obviously, that's not my primary goal for resuscitation is termination, but to be able to use that as a tool, possibly to kind of preserve respect and the care for our patients, that could be an incredible opportunity. And like you, I really like the idea of that, being able to assess the inferior vena cava, looking for that volume up or volume down possibility as well. And I don't think that was an answer, but that was awesome to me.
Now, well, our emergency medicine physicians like Dr. Paladugu, she sends her apologies. Technology is not on her side today, and that's okay. It happens. Yeah, she was sharing with me, and I know a lot about the curriculum, but I wanted her perspective on really how long it takes to get earn proficiency in echocardiograms. And really, she mentioned 2 weeks um, in kind of intensive training on what an ultrasound is, what it looks like, and really about 15 scans, like doing your own 15 scans before you really start seeing things that make sense to you, including kind of signs and symptoms of pericarditis. We're about 5 minutes away. Paula, put it in the chat if there's, or holler up if there's any live questions. Otherwise, I want to pick on Will for for a couple of items. Anybody on the live chat, Paula?
Nope. I'm
Okay.
actually been reading the questions. We don't have any more right now, but as Dr. Salazar just mentioned, we have 5 more minutes. So if you're interested in knowing any extra information or asking a question live, this is the time. So let us know in the chat.
Yeah, absolutely. So Will, back to you. We have this patient, to kind of recap things, that more than likely within the last 2 weeks, impossible to say when, probably developed a myocardial infarction. Probably the day of presentation, he got really symptomatic. God only knows, maybe he had some symptoms before and he just chalked it up to something. And my Latino brethren and sisters out there, sometimes we try to tough things out. I'm going to be very open with you about that. So maybe he was trying to tough it out. But will it, the patient had an ischemic process at some point, then developed these inflammatory changes that led to his pericarditis. And at the end of the day, now you have a myocardial infarction, you have that inflammatory process, and now you also have a thrombus. And this is a well appearing patient. Now, how will this change the way you teach our students signs, symptoms of myocardial infarction going forward?
It would definitely change my focus on, like you noted initially with that crew, the sufficiency and efficiency of our history taking, making sure that we are doing a complete assessment. Again, speaking for myself and some things that I've seen, it's really easy to fall into kind of get that tunnel vision. Once you find something that you think is going on, get some common signs and symptoms, then you just follow a one-track mindset, and you can miss some of these maybe less likely things that are going on here. Like you said, a well-presenting patient that is very, very ill. So stressing the importance of doing that complete assessment, of thinking through your differential diagnoses, making sure to keep them fresh in our minds, to do our best to not glance over things that can have really, really deep significance for our patients.
Thanks, Will. Yeah, I think that is going to be the most important aspect of things. I think keeping a wide differential diagnosis on patients really with minor complaints remains kind of at the top of my priorities for folks. I can see really you're having a tough day. Maybe your 20th run of the day is 4 o'clock in the morning, and a gentleman with very mild right-sided chest pain just came back from a trip. I can see how even I would say, well, maybe it's nothing major, but that is when the maybe it's just something major. Those are the moments where you wish you can take him back. I want to address a very important, very interesting question. Will you make Sono available for classes? I picked up a Butterfly and use it on patients. Yeah, so Butterfly systems are a portable ultrasound system. You have one probe, and the interface is literally your phone. So you can see everything that you need to see from the comfort of your phone. So now, if you're interested in that, one of the things that we've done at UT Southwestern is actually an EMS ultrasound course. Actually, our great Mike Ziem, who's one of our faculty, took part on our most recent one. So maybe for our audience out there, if you're interested and you want to ask CareerCert nicely if they want to help us put a course together on a point of care ultrasound, and maybe perhaps you may be willing to fly to Dallas, and we can we can put probes on patients and actually do it in person and with an online component. Will, would you be interested in something like that?
Definitely.
All right. Well, thank you so much. Once again, we're going to begin to wrap up here. My many thanks to Dr. Paladugu. I will be seeing her later on this week in the emergency department. Will, thank you so very much for your time. Paula, thank you as always for watching over things and making sure everything is tip-top shape. And thanks to all of you who spent an hour with us. So we're going to be respectful of your time. And with that, we're going to kick it back to Paula.
Yeah, thank you so much. Thank you, Dr. Salazar and William. So sorry to everyone that Dr. Paladugo's connection was not great today, but we appreciate you staying with us. And if you'd like to earn CE hours for attending this webinar today, make sure you check your email the next 48 hours. You'll be receiving an email with an exam. You have to just complete it, and that's it. You get a certification, and you're good to go. Just wanted to mention to you, we have a promo through the month of November, so 20% off all our products through our website. So make sure you take advantage of that. You'll have till Cyber Monday to finish that purchase. So that's there. And as always, just thank you for joining our webinars. Visit our website for more free resources, and we hope to see you in the next one. Thank you.
Thank you all very much. Have a good day.
Bye.